Good afternoon, everyone. It's my pleasure to be with you here to discuss one of the most essential pillars in the antimicrobial stewardship, which is optimizing the durations. My name is Sahar Mohammed Hisham. I'm board certified pharmacotherapy specialist, board certified infectious disease and clinical pharmacist licensed in the UAE and holding my master degree in the clinical pharmacy. Over the past years, I have had the privilege to work at the intersection of the clinical practice, antimicrobial resistant management, and education, helping healthcare teams balance the art and science for antimicrobial use. My passion lies in ensuring that every antimicrobial prescribed is not only to be a right drug for the right patient, but also for the right duration, shorter when it is safer and longer when it is truly needed. Today, I will share with you my practical evidence-based insights that bridge the guidelines with the real-world clinical challenges so that together we can improve patient outcome, reduce resistance, preserve the power for our antimicrobial for future use. Now that we have set the stage, let's start with the why the duration matter is so much important. Our ultimate goal in the antimicrobial stewardship is very simple but powerful. Use the shortest effective course to achieve cure. The evidence consistently show that shorter guidelines-based courses give the same cure rates, but with the less harm to the patient, fewer adverse drug reaction, fewer Clostridium difficile rates, low resistance, and even lower cost. When we overuse the antimicrobial, the consequences will be multiplied. More side effects, more Clostridium, higher resistance rate, unnecessary cost. And each of these has direct and indirect effect and lasting impact on our patients, our hospital, and public health. Okay, of course, while we aim for the shortest effective duration, going too short carries always risk for the patient. If therapy is stopped prematurely, we risk the relapse, treatment failure, or even persistent infection. This risk is even higher in the infection that inherently require prolonged treatment, like the endocarditis, vertebral osteomyelitis, where the pathogen is deeply seated and harder to be eradicated. That's why before deciding to stop these antibiotics, we must always confirm two critical things. Source control, which is the infection focus has been addressed, and also the patient stability, where the patient become clinically and hemodynamically stable. On the other side of the spectrum, extending antimicrobial duration unnecessarily comes to the cost and literally will cause much harm. Every extra day increase the risk for adverse drug events, increase cost, increase the nephrotoxicity if the drug is nephrotoxic, increase the rate for Clostridium difficile, and also fuel the selective pressure, giving resistant organisms. And perhaps the most important point, prolonged therapy beyond what is needed offers no added benefit as documented in the guidelines, but does guarantee more resistance, more side effects, and more financial burden. So the good news is that just the guidelines is not a theory. We have proved that the guidelines compliance work. Take an example for the CAP Community Acquired Stewardship Initiative by aligning with the evidence-based recommendation that reduction in the antibiotic course from 10 days to 7 days, and importantly, there will no risk for treatment failure or mortality. This reinforced the key message when we follow evidence-based duration. We have not only being safe, we have being effective, and we are protecting our patient from unnecessary harm. So it is not just words, it's on practice, it works. So how we decide on the right duration? I like to use what is called 3S rule. Absolutely, the 3S rule, it's my rule, okay? It's not from books, but I usually follow these rules, okay? The first S is about source control, and it must be achieved if the source isn't delayed, enough, no duration will be enough. Okay, so the source control is very, very important. Okay. The second S is about the stability of the patient. So the patient must have been stable for at least 48 to 72 hours on the antimicrobial. That's our sign that the infection is truly under control. So if the patient is not being stable on the antimicrobial, the duration surely will be extended. The third S is the specific infection rules must be followed. What's the meaning for this sentence? Even if the patient is stable and the source is being controlled, each infection has its own guidelines based on the maximum and also for the minimum duration, and we should not ignore it at all. Okay? And remember that there is a certain biomarkers like the procalcitonin can help us to shorten the therapy safely. But as we know that the procalcitonin as a biomarker, it does not work for all the infection. It works only for the community-acquired pneumonia and also for the sepsis. So before we stop the antibiotic, we should always confirm the stability, source control, and also we must check the guidelines for that infection duration. Infection duration are either fixed duration or response based. So when it comes to the antibiotic duration, we generally fall in two categories. Either it's fixed duration, so this infection where the course is well established in the guidelines regardless of the how quickly the patient improved. For example, the intra-abdominal infection, the vertebral osteomyelitis, and the endocarditis. The nature of these infections, okay, means that require a set of minimum time to ensure eradication. Second, response-based duration. Here, the length of therapy depends on how quickly the patient responds to the treatment. For example, the community-acquired pneumonia, cellulitis, and even the gram-negative bacteremia. We can often shorten the course if the patient stabilizes early and meets the stopping criteria. So the infection duration may be fixed duration according to the guidelines or response-based. When we use minimum and when we use maximum duration, once we know whether the duration is fixed or response-based, the next step is deciding whether to use minimum or maximum duration. Sometimes there is an infections that in the guidelines, they told you that you should give the patient from 7 to 10 days. When we go to the 7 days and when we go to the 10 days, for example, for CAP, community-acquired pneumonia, if the patient is stable by day 3, so we can stop the antibiotics on day 5, but we can extend if the patient has any complication. Sorry, as I will discuss later at the slides. For the hospital-acquired pneumonia or for ventilator-associated pneumonia, we usually go for 7 days, and it is enough for the patient that is improving. And we can extend the cases if the patient has a multi-drug resistant pathogen or undrained foci. Also for the pyelonephritis, we go shortest around 7 days, and this is according to the 2025 IDC guidelines. Okay, especially if the patient take fluoroquinolones and there's a rapid improvement and the treatment response is well. But if there is no treatment response, the course of therapy can be extended until the infection control is achieved, or we make a reassessment for the patient to know if there is a urinary obstruction, urinary retention, an abscess, or something that is causes the delay in the response of the patient. To make this even more practical, okay, here is a summarized table for some common infection and their recommended duration. And this table is designed by me. I'm not copying it from a reference. So I try to select the infection, I select the typical duration, and then I select the minimum range and the maximum range and when to extend the monitoring for the response for this infection and also the key references. First of all, for community-acquired pneumonia, we have aiming for at least 5 days, with the patient is clinically stable in the first 2 to 3 days from starting of antibiotic. Minimum duration applies if the patient stabilizes quickly without complication, and the maximum or extended duration is needed when the patient shows a slow improvement or there is an extra pulmonary complication like pleural effusion, like the patient goes for the lung abscess or something like that, or even the patient is immunocompromised. For hospital-acquired pneumonia and ventilator-associated pneumonia, collectively it's called nosocomial pneumonia, the standard treatment duration is 7 days. If the patient improves promptly or quickly, but if are ongoing signs of infection for undried foci or multi-drug resistant pathogen, we usually extend the duration. Okay, the monitoring parameters here is the FiO2 over the PEEP if the patient is ventilated, the sputum quality, whether it is viscous and there is an increase in the quantity for the sputum, temperature, white blood cells, radiograph, but take care that the chest imaging usually it takes time to resolve. So we are not relying for the radiograph to know if there is a clinic response or not. And this is the key references for my recommendation according to the IDCA 2016. This is the last update in the IDCA guidelines. And for the uncomplicated skin and soft tissue infection, including uncomplicated cellulitis, it's not purulent, okay? It's only cystitis. We usually goes for 5 days. It's the recommendation is very clear, okay? And we extend it if not improving. If the patient is not improving, we can extend beyond the 5 days, okay? Especially if the patient experienced low response, associated ulcer, or the cellulitis turn purulent, or there is a severe edema. This table is not just in numbers, it's decision-making tool that helps you to guide you whether or not you will stop the antibiotic. You will know the minimum and the maximum duration and correlate this with the clinical response in order to take appropriate decision about the duration of antimicrobials. Here we are continuing our recommendation about the treatment duration, focusing on other common infection like the complicated intra-abdominal infection, post-adequate source control. The main issue here that we make is source control. The duration fixed for 4 days. We usually extend from 5 to 7 days only if there is uncertainty about source control guided by the clinical markers. Okay, usually the monitoring parameters in the intra-abdominal infection is relying on the temperature, white blood cells, GI function, and the drainage collection. Okay, and this is the reference for Stop IT to 2015. It's the guidelines for the intra-abdominal infection and when to stop the antimicrobials. For the acute cholangitis after biliary drainage, it also takes typically takes from 4 to 7 days. Shorter courses are possible if there is a rapid improvement and source control, but we usually extend in the severe sepsis, obstruction, and inadequate drainage. Okay, and also like the other intra-abdominal infection, fever, leukocytosis, and bilirubin, liver function, hemodynamics are the monitoring parameters for us. For uncomplicated cystitis in women, the duration is varying depending on the agent that is being used. So if we use nitrofurantoin, we usually rely for 5 days. Trimethoprim sulfamethoxazole, we usually give the patient 3 days, and fosfomycin, we usually give a single dose. Okay. Always we are ensuring that the pathogen is susceptible and there is no any complicating factor. The next slide, we are moving on to some other high impact infection like complicated UTI, where the duration is 7 to 10 days. Okay, this is usually according to the updates of the guidelines 2025 that recommend that for complicated urinary tract infection, we usually give from 7 to 10 days, and we usually choose the shorter duration if the patient is stable by day 3 and the pathogen is sensitive and there is a good oral option. We usually de-escalate and make IV to oral switch, and the patient take a shorter time, which is 7 days. For the gram-negative bloodstream infection, whether it is it must be uncomplicated. Usually we go for 7 days. It's enough for the patient when the patient being stable, the source is controlled, and there is no any endovascular like endocarditis. We extend for the prosthetic material, persistent bacteremia, and poor source control. And this is according to 2019 randomized clinical trial, and this is the key reference. For diabetic-related food infection, soft tissue, mild to moderate infection, we usually treat the infection from 1 to 2 weeks up to 10 days After debridement, we extend if there is slow response, severe infection, ischemia, or extensive tissue involvement. Okay, and this is according to the 2023 diabetic foot infection guidelines. This is the recent update. The clinical response here in the diabetic related skin and soft tissue infection, depending on the erythema, edema, and the drainage, pain, wound, and the systemic signs if it is present. To wrap up our overview, let's look at the few more important infections and the recommendation duration for native vertebral osteomyelitis. Most patients require 6 weeks of therapy. We can extend in specific situations such as brucella infection. Maybe the patient took antibiotic for 3 months, or if there is retained hardware, so the patient has prosthetic joint infection, debridement and retention. We retain the hardware, so we there's no source control, so we use to give the patient longer duration, slow clinical response, and epidural abscess. For acute bacterial rhinosinusitis, usually goes for 5 to 7 days, generally sufficient for adults who improve early and have a low resistant risk. Longer duration is reserved for those who have severe disease complication or poor clinical response. This is according to IDCA 2012 for acute bacterial rhinosinusitis. For group A streptococcal pharyngitis, the standard treatment is 10 days penicillin or amoxicillin. In patient with penicillin allergy and susceptible isolate, we usually give 5 days azithromycin therapy, may be used according to the local policy if there is no resistance to the azithromycin. For infective endocarditis, native valves usually range from 2 to 6 weeks depending on the organism, while in the prosthetic joint infection, we usually goes for more than 6 weeks. Okay, extended courses are usually needed if the patient has a complication or if there is a certain pathogen like Enterococcus or Staph aureus that is not fully sensitive to the antibiotics. So we can go for extended duration. The blood culture and the clearance for echo inflammatory marker are our clinical response marker. Finally, this lecture was inspired by me from one of my trainees during an online meeting. She asked me a question that sparked this entire session and had the privilege for helping her to organize her thoughts and find right clinical approach. So thank you for her. Just as a guided her, I offered a tailored lecture, workshops, and one-to-one consultation in the infectious diseases antimicrobial stewardship, helping other healthcare professionals to gain clarity, confidence, and measurable results. For more collaboration and booking, you can WhatsApp me at this number for more details. Thank you for all of your attention and engagement today. I hope this session has given you a practical tool to optimize antibiotic duration, shorter when safer and longer only when there is truly needed. If you like to continue the conversation, collaboration, and bring this training to your team, you can reach me directly on the WhatsApp. Together, we can make antimicrobial stewardship a daily habit, not just guidelines. Thank you for all and see you on the next video inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.